The source for contamination is entry of multiple instruments which may carry the periocular bacteria from the lids, lashes and ocular surface into the eye, and also there is a chance for a retrograde reflex either during or after the surgery. And this rate of intraocular bacterial contamination has been shown, some evidence is there, it is as high as 31%. So why do we give antibiotic? We intend to kill any intraocular bacteria that may have gained entry during the procedure from the things which we use or from the ocular flora, and we would like to achieve extremely high concentration that may persist for many hours after the cataract surgery. And if you see, the most commonly used antibiotics are cephalosporin, especially cefuroxime and cefazolin, vancomycin, and we have moxifloxacin, which is being used as a routine practice nowadays. If you want to see the evidence for antibiotics, it's been there for quite some time. ESCRS has done a big trial with 16,000 patients comparing cefuroxime and levofloxacin, and they found a significant reduction in endophthalmitis from 0.35% to 0.08%. And this has been a routine practice now across Europe to use intracameral antibiotics, especially cefuroxime. And vancomycin is also been used in several parts, including in Australia, where they found it's highly efficacious, and also if you talk about cost effectiveness of intracameral vancomycin, it's cost effective to use this, and they have found a 9-fold reduction in the rate of acute postoperative endophthalmitis. When we come to moxifloxacin, we have been using this extensively for the last 4-5 years now, and we have a lot of evidence to share with. These are some of the work where there is almost a 4-fold reduction, and we also saw how it works in 600,000 eyes, and also recently we have a series of 2 million eyes, 1 million with and 1 million without, and a significant reduction, almost a 4 to 5-fold reduction in endophthalmitis. But I'm sure the opponent will be worried about increasing bacterial resistance, the cost of using this, and also the complication and side effects. But to make it simple, this one-time highly concentrated dose of antibiotic injected into this physiological isolated space is extremely unlikely to promote a bacterial resistance. There is no good evidence to prove this. And if you take our study, we found that just by reducing the management of some of these complications, in just 24 patients, we can kind of offset the additional cost of giving these antibiotics to several thousand patients. Because we are seeing again only the provider cost here. If you say the patient cost, it will really go to a very high level. And side effects and complication due to IC antibiotic is very rare, and the real incidence is also not known. There are very odd reports about this. So just to conclude, I would recommend intracameral antibiotic always and every time, and the choice depends upon the clinical situation, and in our context Moxi works really well. And if you have a PCR, it's a must. We would use it always, but in a PCR it's a must. Thank you.